We'll start, sir. Yes, sir. Yes, sir. So please, Dr. Ravi, please take it.
Good afternoon, everyone. A warm welcome to all the students. I welcome you all to the last session of the virtual pediatric rapid revision 6. The topic for today's session is advanced pediatric dentistry and MDS exam preparation. We have three eminent panelists for today: Dr. ChandrashekharYavagal sir, Dr. Shital Kiran sir, and Dr. Sivakumar Nuvvula sir. The session will be moderated by Dr. Varinder Goyal sir and Dr. Suresh BS sir. I would like to introduce the first moderator, Dr. Varinder Goyal sir, who is joining from day one with us. He's been the backbone of this virtual pediatric rapid revision program. Thank you so much, sir. Thank you so much for your support.
Thank
sir
you,
is a professor and chair at the Department of Pediatric Dentistry, Guru Nanak Dev Dental College and Research Institute, Sunam, India. Sir is the chair of the IAPD Education Committee and past president of the South Asian Association of Pediatric Dentistry. Sir serves on the board of the Pediatric Dental Association of Asia and is a past president of ISPPD. Sir is also a member of Faculty of Dental Surgery, Royal College of Physicians and Surgeons, Glasgow, and adjunct faculty at Dr. D.Y. Patil University in Pune. Sir is also a member of many professional bodies like ADA, IAPD, AAPD, EAPD, IADR, and many more. Sir has published many papers in international and national journals. A warm welcome to you, sir.
Thank you so much. Thank you.
Next moderator for the session will be Dr. Suresh BS sir. Sir is the principal at Subbaya Institute of Dental Sciences, Shimoga, Karnataka. Sir is a member faculty of dentistry from 2023 to 2026 at RGHS Bangalore, Karnataka. Sir is an EC member of the ISPPD. Sir is an ex-member of the Dental Council of India. Sir has more than teaching experience of 24 years in pediatric dentistry. I warmly welcome Dr. Suresh sir.
Varinder sir, you forgot to stream it.
Can you come again?
Live stream, sir. Actually, live stream is not
going on. First session would be on pain management in pediatric dentistry by Dr. ChandrashekharYavagal sir. I would like to ask Dr. Varinder Goyal sir to introduce the first speaker, Dr. ChandrashekharYavagal sir.
Very good afternoon to all of you. Srinivas, thank you so much for a wonderful introduction. Although I want to share my credentials, I don't know how you got it, but that's okay. Thank you so much. Now I feel very special and honored and very privileged to introduce today's speaker for this last session of Pedia Rapid Revision Program 6, that is 2025. He's none other than our very own Dr. ChandrashekharYavagal. Dr. ChandrashekharYavagal is currently the senior professor and he's the guide for the postgraduates in the Department of Pediatric Dentistry, Bapuji Dental College, Davangere. And he's president of Asia Pacific Laser Institute, Taiwan, and he's the chair for Scientific Committee, Asian Academy of Laser Therapy, and he is the vice president of International College for Light Medicine and Laser Therapy, Germany. He has done his VDS from SDF Harvard, and he has done his MDS as first ranker from Rajiv Gandhi University. And he is a diplomat in orthodontics, and he has done PhD in laser biophotonics. And I always remember the day when I heard him first time in Chandigarh when we had a convention. And Dr. V.V. Subbareddy was supposed to give that lecture, and by chance he couldn't come. Then he sent his postgraduate, and he was ChandrashekharYavagal, to deliver that lecture on caries. And it was amazing. I was really impressed. And till today, you always impressed me with your lectures, Yavagal. It's an honor to chair your session. Thank you for being there.
Sir, an absolute pleasure and honor to get introduced from none other than Dr. Varinder Goyal. Thanks to Madhu sir for giving me this invite. It's actually an honor to be speaking to the young minds of our profession who are going to be our flag bearers in the future. Thank you for that kind introduction, sir. Can I start the screen share?
Yes, sir, please.
Yes, please.
So when Madhu sir requested me to... is this fine, sir?
Yes, sir, it's fine.
Great. I'm going live. So that's the reason why I had not sent you the recording.
Absolutely. That's absolutely right. We can see you.
Thank you so much, sir. Thank you so much. Well, this is what I'll be trying to cover in the next 35 minutes. We'll first try and understand what is pain, what is the pain pathway, how the pain physiology and perception varies in adults and children. What do we exactly mean by peripheral sensitization and the central variant of it? How do we manage pain in children? Conclusion and references. So when the moderator, before the moderator introduced me, the person who started this session, Dr. Ravi, mentioned that this is the advanced part of the forum. According to me, this is the most basic part, because whatever I do in a child's mouth, I would be failing in my duty if the child leaves the operatory with tears in his or her eyes. I've been a wet-fingered clinician for the last 2 decades, and every single day I get judged not by the kind of restorations that I do or the crowns that I place. I get judged by whether the child was pain-free during the treatment, and did the child leave with a smile on the face, and on the follow-up 48 hours later, 72 hours later, what kind of a feedback the parents give us. Will they curse us by telling that you did something and the patient had terrible amounts of pain in the first 2-3 days? Or will they come back and tell us, doctor, kuch hua hi nahi usko? I mean, you had given us so many tablets and nothing. The child was absolutely comfortable. So according to me, this is something that is very basic. In fact, mera periodontic treatment triangle isi se start hota hai. I have to leave my child patient smiling. This is from a very famous textbook of endodontics by Dr. Ingle. And the legend has that this was Dr. Ingle's own grandson. He had a bad dentoalveolar abscess which needed drainage extraorally. And Professor Ingle himself did this. And the moment this grandson went out, he took a piece of charcoal that was lying there on the floor and wrote something right below the board of his grandfather, which claimed to be a painless dentist. What did he write? He said, L-I-A-R, liar. I mean, which grandfather would do this to his grandson? Are we missing the trick somewhere? We are experts in local anesthesia. We have read Malamed upside down. Then why is it that the patients are not comfortable when we deliver the treatment, or once we complete delivering the treatment, why is it that they fail to understand that we have tried our level best, but the patient goes back home and tells, bloody root canal, itna dard hua, and then the child was wincing with pain for 2 or 3 days. Why does this happen? Do we miss this point to reach the mind of the child before we reach the mouth? What do we exactly mean by that? Well, forget children. Fear of the dentist is ranked as the number 2 fear of all times. As in, this was a survey done in the United States of America, which said that people hate coming to us. That this is the fact. I mean, I'm talking about adults. Imagine what could be the plight of the young, innocent children that we treat. So, as much as you would hate to hear me say this, nobody enjoys coming to us. The only reason they come to us, I mean, barring the aesthetic procedures, the only reason they come to us and the point at which they come to us is when the pain is unbearable. So it's our duty to first address pain and then show our prowess with all the clinical skills that we have. In fact, if you go to Google and try this exercise, all the postgraduates, I want you all to understand what exactly it is to be a wet-fingered pediatric dentist. You are answerable to the child's parents. You have that moral obligation to ensure that what you do in the child's mouth is absolutely pain-free. And that can happen only when we have a thorough understanding about what exactly is pain. You try this, fear of dentist is ranked, on this list also as number 1. Right? So pain relief is not advanced. It is basic according to me. Pehle ye karo, and then you talk about your crowns and maintainers and, and all the other great things that you are skilled to be doing. So the number 1 reason which brings a patient to us more often than not is pain, right? So basically, how do we define that? It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And what do we actually mean by a nociceptor? A high threshold sensory receptor, which perceives this sensation, which transducts a signal. Sometimes there is increased pain from a stimulus that normally provokes pain, and that we call as hyperalgesia. Sometimes it is not nociception, it is neuropathy. That means there is a lesion or a disease in the somatosensory nervous system. Either the nerve is damaged or a ganglion is damaged, and that ends up giving neuropathic pain. What is allodynia? Allodynia is pain due to a stimulus that does not normally provoke pain. That is, it is not expected to provoke pain, but it does. What is sensitization? You will hear this term again and again and again for the next 45 minutes. What is sensitization? Increased responsiveness of nociceptive neurons to their normal input. Uska ek threshold hota hai. Only when that threshold crosses, it should fire an action potential. If it keeps responding to every small nociceptive signal, that means the system is pre-sensitized. And whatever we do to block those sensations with an infiltration or with a block or with any other forms of pharmacological behavior management, we usually fail because the child is already entered a phase where the CNS is pre-sensitized to pain. So the description of pain does not actually match the actual input. That is where we use the term sensitization. So why do we need pain? Is it good at all? People say that yes, it gives a warning signal and it prevents further damage, forces the person to rest, or it urges the person to take required treatment to prevent further damage. So it would be appropriate for me to say pain is subjective, pain is biologically useful, it is pro-survival. What do I mean by pro-survival? For example, if there is a burning candle, right? Imagine this is a burning candle and I place my palm over the burning candle, and imagine if I do not understand that my palm is being burnt, I am never going to take that palm out. Correct? So it is pro-survival. Only when I get an impulse and my brain decides, nahi, this is something dangerous for you, this can cause damage, I'll take it out. So this is pro-survival and it's a response to damage. So it's not bad all the time. But when it crosses a certain limit and it starts bothering the course of delivery of the dental treatment or during the recovery period, it becomes a concern for us. How do you classify pain? Traditionally, it was classified as acute and chronic. Chronic was further classified as nociceptive and neuropathic. Neuropathic was further classified as central and peripheral. This was the old classification. We now have a new classification which demarcates acute and chronic by not just by duration, but also the cause for it. That means anything that is less than 3 months in duration is usually categorized as acute. That is the duration part. And anything that has an injury which is evoking a response, where there is nociception which is evoking a response, it is acute. The moment it crosses 3 months or the healing gets extended and the inflammation persists way beyond the healing period, it becomes chronic. And sometimes it could become dysfunctional, neuropathic, wherein there is a permanent damage to the nerve bundle or the ganglion, and it starts misfiring signals even when there is no actual nociception. Right? So this is how we classify it. When we look at the acute pain physiology, we know that there are various nerve types. We have the A alpha, which are large insulated fibers, neurons. We have the A beta, which are medium-sized and again insulated. Then we have the small insulated A delta fibers, which are very important for us as pediatric dentists. And also we have the uninsulated ones. When I say insulated ones, I'm talking about the myelin sheath. So obviously the conduction will be faster in a myelinated nerve because the action potential jumps from one node of Ranvier to the other. Whereas in an uninsulated one, this does not happen. It is slow. So it is usually kind of more of itching or burn, which is associated with a muscle or ligament. Whereas a fast tissue damage, for example, like a needle prick or an intense heat, is more due to the stimulation of the A delta fibers. A alpha and beta are more to do with proprioception. So we'll keep them out of our discussion for now. Right? So acute pain is caused by stimulation of pain receptors, as we understood. And the A delta fibers carry acute and localized pain sensations that are occurring during the noxious stimulus. That means there is a prick happening. Like I told you, the example of the burning candle. I place my palm and it gets triggered and I understand that mujhe haath hatana hai. Otherwise, it is going to cause more damage. Whereas the continuing pain sensation where the stimulus has been removed, the dull kind of a pain where it is slow to conduct, is usually because of the unmyelinated fibers where the action potential cannot jump from one node of Ranvier to the other. So the velocity of this is very low. typically about 0.5 to 2 meters per second. These are the unmyelinated C fibers. So the sensation of pain is pursued not only in the damaged area, वो pinpointed नहीं होता है, dull होता है, and it is widespread, and it sort of spreads on to the neighboring regions because of its way the sensation or the impulse is getting conducted. So that's how we demarcate whether it is a nociception from A delta or from the C fibers. Where does the signal go from there? We know this, right? The pain pathway. We know that there is a tissue injury, then there is transaction, and then there is the first order neuron. The first order neuron decussates at the level of the dorsal root ganglion, then the second order neurons, and finally the third order neurons relay the sensation in the thalamus or the sensory cortex, where it is perceived as being painful. Now, we have been missing a trick in our practice for ages. We are experts in blocking peripheral stimulation. Are we doing anything to change the central perception? When we talk about nitrous oxide, when we talk about conscious sedation, when we talk about relative analgesia, we are exactly doing that. We are not just relying on local anesthetics to block the peripheral sensation. We are, in fact, changing the way the somatosensory cortex and the thalamus respond to that pain. So we are ticking both the boxes. We are blocking the peripheral stimulation and also changing the central perception of that pain. And that is the reason why we get better results and the child is cooperative during the treatment. So when we talk about pain being a subjective experience, there are 4 distinct processes that we have to respect. One is the electrical activity produced by the noxious stimulus. There has to be an action potential that has to get triggered. That is called as transduction. Once it is triggered, it has to be input into the CNS. My central nervous system has to know that there is a burning candle here and I've placed my palm over it. Correct? So that input is through transmission, and then the perception could be subjective. Imagine you are playing on a football field and you get hurt. For hours together, you continue playing. You are not even aware that you have hurt your foot. Imagine you are sitting in a boring class in the afternoon and your hand bangs against the desk. You suddenly feel that your hand is fractured. Why? Because mahol alag hai, right? What you are faced with when there is a restrictive environment may actually give you a subjective sensation of pain, which is more. Perception is more. You look at our brave military men, right? There are instances where they were actually subjected to amputation as a result of an enemy missile hitting them or an injury that happened during the work. They continued to fight on the borders. So many instances. उनको पता भी नहीं है because उनका जुनून जो रहता है, the kind of passion that they have to serve the country, their brain perceives it differently. हम लोग एक छोटा सा अगर चींटी भी काटा ना, we make a big hue and cry because our brain is programmed to react that way. So perception is everything. Simply blocking the peripheral stimulation is only 50% job done. So the modulation part will come to that when we understand the Melzack and Wall's gate control theory as to perceive होने के बाद what does the central nervous system and our higher senses do? The somatosensory cortex and thalamus, what do they respond? How do they respond? And try to modulate the pain that is arising. So these are 4 core processes which have to be understood. When we talk about the general pain sensations in the body, there are 2 pathways which are very important. The neospinothalamic pathway, which is for the A delta fibers. Like I told you, the first order neurons, they decussate at the level of the dorsal root ganglion, and then they are relayed further to the higher systems. And the paleospinothalamic pathway, which is more common for the C fibers. Now, for the orofacial regions, the dynamics are a little different. So rather than looking at the generic way of understanding pain, let us be a little more specific and understand how exactly the pain pathway behaves or the pain physiology behaves in the head and neck, primarily arising from the teeth and the gums and the TM joint. So when you look at the A delta and the C fibers, there are few things which I want you all to understand. One is the cell body in the dorsal root ganglion and the dorsal horn of the spinal cord, after which they decussate. So this is important because we are going to draw parallels and understand how the general pain physiology is a little different from the orofacial pain physiology, right? How is it different? I'll come to that in a little while from now. But what I want you all to understand is that if there is an ascending pathway, please appreciate that there is a descending pathway also. That is common between general pain and orofacial pain. क्या करता है ये? What does this descending pathway do? This descending pathway is important for the release of endorphins and enkephalins and monoamines like serotonin and norepinephrine, which will close the gate at the level of the dorsal root ganglion. Why is the gate important? The gate is important because that is going to decide how much of the signals will be allowed further and what will get blocked at the level of the DRG, right? So a quick video to explain exactly what is modulation, how it happens at the level of the DRG, how the body decides which impulses to be allowed and which impulses to be blocked. That's the Melzack and Wall's gate control theory in a graphic form for you. I hope my audio is visible.
A set of ascending pathways that convey nociceptive information.
I'm not sure if the audio was heard. Let me try and reshare that.
No, it's very well heard.
Sorry,
Okay.
sir. Sorry. Just give me a second.
Hello? Yeah.
Yes, sir.
Yeah.
The pain system involves a set of ascending pathways that convey nociceptive information from peripheral nociceptors via interneurons in the spinal cord to higher levels of the central nervous system, including the brain, where the pain is perceived, interpreted, and the information processed to modulate pain. As there exists an ascending pain pathway from the spinal cord to the brain, there is also a descending pathway from the brain to the spinal cord. That increases the amount of neurotransmitters like noradrenaline in synapses of the spinal cord, where the ascending and descending pathways meet. The action of noradrenaline at this site reduces the transmission of ascending pain signals to the brain.
So please remember noradrenaline and serotonin. I'll come to that again when we discuss how different pain physiology is in the orofacial region. In the orofacial region, we have the primary afferent neurons, and whatever changes we talked about in the cell body of the dorsal root are actually happening in the trigeminal ganglia, the fifth cranial nerve. And then we have the brainstem nociceptive neurons, which are not one, there is a set of three. And then it goes and gets relayed in the thalamus, and the higher brain functions, the somatosensory cortex and the thalamus, regulate orofacial nociception. वो decide करेगा कि how much it has to be modulated and how much is allowed. So basically, if you see the pain physiology in the orofacial region, it is a little different than the general body pain physiology. Here, our first order neurons are passing and first entering the trigeminal ganglia and then to the trigeminal nucleus caudalis. Wahan se second order neurons will ascend up and the third order neurons will ultimately relay that pain in the thalamus. So यहाँ पे क्या हुआ? What's the difference between the generic pain pathway and the orofacial pain pathway? The trigeminal ganglia is the analog or is the substitute for what we call as the DRG in the spinal cord. And the dorsal horn of the spinal cord here, that role is played by the trigeminal nucleus caudalis. If you look at this, you have the midbrain, you have the pons and the medulla, and in that we have three sets of neurons, right? If you pay attention, the spinal nucleus of CN5, that is cranial nerve 5, has three parts. The one that is important for us is the pars caudalis because that is related with pain. The pars interpolaris is more to do with the tactile sensations, and that is not a part of our discussion today. So let's look at the pars caudalis part, which has three different sets of neurons. And when we talk about higher brain functions regulating orofacial nociception, there are three things which we have to remember very clearly. The descending pathway here is made up of the periaqueductal gray area, the locus coeruleus, and the rostral ventromedial medulla. Sounds very complicated, but it is not. The clinical importance will make you understand that LC, that is the locus coeruleus, is composed of non-adrenergic neurons. So I had asked you to remember, when we looked at the Melzack and Wall's gate control theory, the generic form of it for the whole body pain physiology, I told you remember two things: noradrenaline, serotonin. So these have specific neurons in the orofacial region. Why is this important? When I talk about pain management, you should be able to exactly correlate what aspect of this pain pathway is being intercepted by a particular pain management tool that we are using. Without knowing this, simply using ABC methods for blocking pain sensation will usually not yield good clinical results. Whether you are using pharmacological means or other means to block the pain pathway, you need to know exactly where you are intervening. So if your intervention is releasing non-adrenaline in the orofacial area, it is at the locus coeruleus. If it is releasing serotonin, the feel-good hormone, the pain modulator, the natural pain modulator, it is at the RVM, that is the rostral ventromedial medulla, right? Now, what has changed in our understanding of chronic pain? We discussed the acute pain physiology. What about chronic pain? The current concepts are mind-blowing, actually. The current concepts say that pain today is not so much of an input into the brain, it is an output from the brain. What do I mean by that? Afferent nerves transmit nociceptive input to the brain, and the brain determines the level of threat and then decides whether to give you pain, whether to give you tenderness, or whether to give you restriction in the movement. Here again, the subjective thing is so important. Here again, the descending pathway is so important. Here again, the setting in which you experience that pain is so important. The way a child behaves to a certain nociceptive signal inside a school classroom is completely different on how he or she responds in a school playground. The same child responds to the same painful stimulus differently when he is in a dental operatory. This is exactly what we have understood. The body at times literally becomes a sensitized, and once it is a sensitized, physically, emotionally, thoughts, patterns, previous baggages, once it is sensitized, आप कुछ भी करो, block दो, infiltration दो, whatever you do, the pain that the patient demonstrates or experiences is no longer an accurate reflection of the biological damage. कुछ हुआ है ही नहीं. You are not doing any vital pulpectomy without giving an LA. सब कर रहे हो आप. But if the body is pre-sensitized, the pain that the patient complains of is no longer an accurate reflection of the biological damage present. Here again, it becomes so important for us as clinicians to understand peripheral blockage se kuch nahi hoga. You need to understand how to reach the mind of the child before reaching the mouth. That means you need to understand how not to let the central system get pre-sensitized, because the perception of pain and the modulation is done from there. Aap kitna bhi block karo, whatever ultimately is going to happen through the descending pathway, and that's where we have to revisit the Melzack and Wall's gate control theory. Kya kar rahe ho aap? When we talk about any pain management strategy, let's say you are using a local anesthetic. Exactly what are you doing? You are only blocking the peripheral nociceptors. Kya hoga usse? Kuch nahi hoga. The impulses which are getting generated may get temporarily blocked. But then when you go one step further, and if the patient is on, say, antidepressants, the level at which it works is at the peripheral nerve. Along with local anesthetics, if you give, say, NSAIDs or coxibs or opioids, you are hitting the dorsal root of the spinal cord. But if you do something like pain modulation at the central level, I told you about relative analgesia, using nitrous oxide, or using something like laser photobiomodulation, you are actually stimulating the descending pathway to release noradrenaline and serotonin. That is where you are going to get the benefit of achieving a peripheral block as well as a favorable central perception. It will appear less threatful to the brain because it perceives it differently, and the descending pathway will ensure that it blocks the gate at the dorsal root ganglion. So jab gate block hoga, the impulses cannot move forward. So this is something that we need to remember before we talk about any pain management strategy. So how do you decide on a pain management strategy? Is it a one size fits all kind of a thing? अभी सबका we know what is rule of 10. सबको वही block दिया, सबको वही infiltration दिया, and you expect every child to behave the same way. You do a perfect obturation, everything is fine. One child goes back home and tells, I was absolutely okay the next day. And the other child, where you have used a similar technique, a similar method, the parent calls up and tells, what is this? The child is wincing in pain. वो रात भर सोई नहीं है. Why? Because this one size fits all kind of an approach is not going to help us. Pain management has to be customized to suit to the threshold and the central perception levels of each patient. Pain intensity is usually most prevalent in the inflammatory phase. We all know that during the first few hours or days after injury. And in most cases, it should decrease as the tissue repair happen, but it doesn't happen all the time. So you might think of taking a radiograph the next appointment and you see what you have done is perfectly fine, but the patient still keeps complaining of pain. You see a perfectly placed crown, perfectly pulpectomized tooth, still the patient complains of pain. So does that mean that the periapical lesion has not healed well, or is the inflammatory pain responsible for the future nociception? Kya matlab hai uska? What is the connection between inflammation and pain? We know the 5 classical signs of inflammation: Ruber, Dolor, Calor, Functionalessa. What do we mean by that? What is the connection between inflammation and pain? Inflammation is supposed to be our guardian, but sometimes it hypersensitizes the site where the damage has happened. Even during the healing phase, the inflammatory pro-mediators themselves will start causing nociception. That means threat is over, but the persisting pro-inflammatory molecules will keep on stimulating this trigger. We talk about TRPV1. What do we mean by TRPV1? Transient receptor potential of vanilloid 1. Please write this down. You write this in your answer on pain pathway. You will impress the examiner. TRPV1, transient receptor potential of vanilloid 1. They are like gatekeepers. They decide how much of calcium has to be allowed inside and how much of calcium should be allowed outside. So that is going to determine how much of threshold will be maintained to fire an action potential. So if you close the gate, if TRPV1 is blocked, the action potential will not fire. Do we have the mechanisms available today to block TRPV1? Exactly. That is why I'm giving you this foundation, so that when we talk about the pain management, you exactly are able to corroborate and understand kaun sa strategy kahan pe block karega. So remember this, TRPV1, transient receptor of potential vanilloid 1. I'll tell you which of our modalities will specifically block TRPV1. So the point that we need to understand is, you may have done your procedure. The pain part, the acute part of blocking it, you have already done. But that doesn't mean your job is over. If the inflammation in that area persists, then it will keep on triggering nociception. That is, it will keep on sensitizing the system. So your strategy should be, it is not a very smart thing sometimes to prescribe a painkiller and tell, use it as SOS. What does that mean? So that means you ask the patient to take it soon after the extraction, and then you tell that, okay, kal dekhenge, agar hua to lo, nahi hua to mat lo. I'm not saying it is wrong, but it is not a very foolproof strategy. It's not a comprehensive way of managing pain, because the inflammation may persist way beyond the acute phase or way beyond the initial few hours when you have given an analgesic to the patient and then asked him to stop it. I'm not saying that you have to give it like a course for 5 days. At least the first 2 to 3 days, when you are 100% sure that the inflammation is still there, it's a wise strategy to put the patient on anti-inflammatory analgesics, even when the seemingly harmful symptoms of frank pain are over. I know this is a controversial statement, more to do with a clinician and less of an academician, because for me, my reputation comes first. And if the parents say that whatever you did, you used a laser, you did not use a laser, the first 48 to 72 hours after the procedure were critical and the patient was having too much pain, then I would have failed in my duty, right? So for me, as much as blocking peripheral stimulation is important, it is even more important to prevent central sensitization. So I don't look at only injury, I don't look at only inflammatory cycles, I look at how can I stop ectopic discharge of primary efferents. Matlab, jab kuch hai hi nahi and still the primary efferents are getting fired, that means I have failed in preventing central sensitization. This is something that every practicing dentist should understand. What you do on the dental chair during a procedure is only peripheral blockade.
unless you have a strategy in place which will change the way the CNS perceives that pain and modulates it by releasing less threatful and more pain-free pathways which are going to help in the healing phase, like what I told you, the release of serotonin, release of noradrenaline. We are constantly going to hear this complaint कि जब तक LA दिया था, block काम कर रहा था, तब तक it was fine. After that, it started paining again. Right? So understand allodynia, primary hyperalgesia, and what happens after your primary nociception is gone, secondary hyperalgesia. These are all stepping stones towards what we ultimately end up when we should avoid that, and that is chronic pain. When you end up in chronic pain, like I told you, it could be neuropathic or it could be inflammatory, where there is no potential threat, there is no nociception, but the pro-mediators which are getting released because of the persistence of the inflammation or damage to the nerve will keep on firing or triggering ectopic triggers or ectopic impulses for which there is no solution. So how is the pain pathway different in adults and children? Let me quickly rush through this. I'll be more than glad to share this presentation with people who want to read this, so you can have a clear demarcation between the parameters and children and adults, how they behave differently neurological development wise. The children are having more incomplete myelination of A delta and C fibers, underdeveloped descending inhibitory control. So जो हम लोग Melzack and gate control की बात कर रहे थे, that is a little underdeveloped in children. Obviously, the pain threshold is less. The cognitive ability to understand the cause and the effect leads to exaggerated perception. See, what were we talking about? This is exactly what we need to understand about the current concepts of pain. Input तो ठीक है, input आप block कर लोगे, output को कैसे block करोगे? So if your child's brain keeps on thinking and giving exaggerated responses, आप जो भी block करो, it is not going to work. Emotional response, higher levels of fear can amplify pain. Anxiety can amplify pain. So just don't look at a cooperative child and tell, चलो अभी करेंगे 3 extraction, 2 pulpectomy because you're cooperative. No. The child could still be anxious and it could amplify the pain that the child experiences on the chair or off the chair after you have completed your treatment. The expression also is different. Adults can articulate, they can speak, they can tell you that I'm not comfortable. A child will rely on crying, on facial expressions. So unless you are a good human being, you cannot be a good pediatric dentist. Observe your child. Is he comfortable? Is he showing signs that he is not able to cope with the situation? Because that may be his way of expressing pain, right? Pain assessment tools are different. Memory and anticipation completely different. Behavioral reaction different. Response to analgesics is different. Clinical implications wise, completely different, because even a cooperative child will need basic tell shoe do, basic behavior management, basic distraction, so that his central nervous system perceives the situation to be less stressful. You can't say I'm using Articaine, I have the best pain blocking agent in the world. Doesn't matter. You are simply working on the peripheral stimulation. You still have to work on the central perception. Whereas with adults, we are more concerned about the informed consent and other things. Whereas with children, empathy comes first, right? So how do we manage pain? When we talk about analgesics, we are talking about anti-inflammatory analgesics. We categorize them as opioids, non-opioids. Under non-opioids, we have the NSAIDs, we have the steroids, and we have the anticonvulsants. When we talk about a non-steroidal anti-inflammatory drug, we typically look at it as an antipyretic first. So when you look at paracetamol, when you look at Dolo, it is an antipyretic first. And it has decent levels of nociception and anti-inflammatory action, not very profound. So if you are looking at a profound anti-inflammatory nociceptive effects, you may have to add an ibuprofen with the paracetamol. What's the mechanism of action? Cyclooxygenase pathway. I'm sure you guys will be aware of this, how it is induced, what is COX-1 gene transcription and what is COX-2 gene transcription. This is important for us because based on the blocking of the COX-1 and COX-2, we are going to ultimately determine the release of prostaglandins and what role they are going to play in the entire cascade. So when we talk about classifying NSAIDs, this is what comes in handy. We block them, or we categorize them as non-selective COX inhibitors, which will block both COX-1 and COX-2. Preferential COX-2 inhibitors like nimesulide. Of course, we don't use nimesulide now. More of aceclofenac these days. Or we have selective COX-2 inhibitors like etoricoxib or paracoxib. Etoricoxib works fantastically well for bone pain. I use it a lot for those children or those young adults who complain of a hit on the chin and the TMJ is paining, there is bone related pain. Etoricoxib works very well. Analgesic antipyretics with poor anti-inflammatory action. It's not a great strategy to prescribe only dolo right, left, and center, right? Because it's a poor anti-inflammatory to begin with. It's more of a predominant antipyretic drug, right? So moving further, we can talk about the selective or advantages and disadvantages of selected NSAIDs, and that will also help us to choose the right one. If you are using a generic COX blocker, you will definitely subject the child or the patient to a lot of gastric side effects because the protective mechanism is gone. So that is why when we talk about selective COX-2 inhibition, we talk about less GI irritation because the protective work that is being done is not blocked. So you need to choose this in a very, very conscious manner. You don't have to rely on the guy who comes with a suitcase to your department and gives you a sample. Usne bol diya hai, we have launched a new drug last month, you write. That's a very stupid way of learning science. You need to go do your R&D because your name is at stake. The child trusts you, the parents trust you. What you prescribe on your prescription pad has to be customized to suit to the pain management requirements of that child. So this is a complete list of those things which are not very important for children because the interactions are less, because usually this polypharmacy kind of a situation arises in adults. An adult patient whom you are prescribing an NSAID he could be an alcoholic, or he could be on antiplatelet agents, he could be on potassium supplements, he could be on chemotherapy. Usually these interactions are less in children, so let's not waste too much time on that. If somebody wants to take a screenshot or wants this, I'll be more than glad to share it. Opioids are not very important in our routine clinical practice, but the American guidelines are a little different. They do not combine two non-steroidal anti-inflammatory drugs. If they are combining paracetamol, which they call it as acetaminophen there, they usually combine it with a codeine, right? So that's how they use it. But opioid crisis now has hit USA so badly that they are looking at other alternatives. I'll come to that in a little while from now. Just for you to have a completeness of the presentation, you can categorize opioids as natural, semi-synthetic, and synthetic. How the opioid works, we all know the gamma-aminobutyric acid related inhibition, which is so important. Activation of the opioid receptor decreases the calcium influx in response to incoming action potentials. This decrease release of excitatory neurotransmitters such as glutamate is what is the game changer in opioids. We use tramadol very rarely, but yes, sometimes tramadol can be used along with paracetamol for especially cancer-related pain, which is way too intense. Other than that, again, like I said, drug interactions with opioid analgesics are more common, but again, less important in children because usually polypharmacy is not an issue in child patients. What does the AAPD recommend? More than 25% of children aged 3 to 12 years first exposure to opioids was through their dentist. Stupid statistic. This is not from India, right? Which Indian dentist prescribes opioids? I don't agree with this, just for the sake of completion. That's why I said your academic protocols may not be very relevant for a clinician. For us, we start our management with a simple dolo and a simple substitute, maybe with a mefenamic acid. That's my go-to prescription all the time. Now that I'll tell you about how you can substitute that with a drug-free way of blocking it by using lasers. Even that has reduced in my practice. But just for completion's sake, these are the classes of analgesic medications and their potential efficacy against particular modalities of pain. You could just use this for completing your answer if there is a full question on pain management in children. Again, how do you choose it? Based on the intensity, mild, moderate, severe. So usually I have never, in my 20 years of practice, never used an opioid. But then yes, for the sake of completion, you can mention that in your answer. Examples of between class combinations. This is very common in the US. Like I told you, they always combine acetaminophen with a codeine. We are more comfortable combining one NSAID with another NSAID as per the Indian pharmacopoeia. But the US pharmacopoeia, the guidelines are a little different. These are the AAPD guidelines in collaboration with University of Penn and University of Pittsburgh, how they decide what pain management strategy to use. So they follow this protocol. Again, not very suited for our setting, but yes, for the sake of completion, you can write this in your answer. So they demarcate it this way. What's the first line? What's the second line? their first line is an ibuprofen. Again, not very smart. You could achieve the same level of anti-inflammatory effect with a simple paracetamol and maybe an added mefenamic acid. Correct? Option 2 is naproxen. We usually don't use naproxen in India. Option 3 is combining that with a rectal suspension or a suppository. I do that usually when I do a case under GA. And if I anticipate pain during the recovery period, then I use a suppository, but not otherwise, right? Using a suppository, placing it in a young patient is so cumbersome, right? Unless the kid is very small and the nurse places the suppository during the recovery phase where the child has not fully recovered from GA, only then a diclofenac suppository will work fantastically well, right? What is the WHO analgesic and side effect ladder? Like I said, we always start with non-opioid adjuvants. Maybe with a little pain persistence, they suggest opioids. I still don't. You have to combine that with a second NSAID and then consider opioids only when you rise higher on this rung of the ladders for the analgesic and side effects, right? What are the neuromodulatory methods that we can use? We can, like I told you, as much as peripheral stimulation is important, central perception is even more important. So you have to understand neuromodulatory processes or methods in which you can change the way the CNS responds to that pain. So few things: transcutaneous electrical nerve stimulation, not very handy, but these days we have units where TENS is combined with a laser. So you have transcutaneous electrical nerve stimulation and a laser PBM device going hand in hand, a little handpiece where both the things are there. But traditionally they were very cumbersome to use. But yes, they could be used as adjuvants with local anesthesia. They could be used to treat other problems like xerostomia, chronic pain. In pediatric dentistry, it has been suggested as a part of the physical therapy for treatment of TM joint disorders, but not very common in children. Other common uses include, as you know, it has to be used in conjunction with maybe a topical anesthetic just before using your local anesthetic injection. This is what I do left, right, and center. And I directly play with the cells at the level at which they respond. I'd asked you to remember one thing: transient receptor potential of vanilloid 1. Can you see that on this slide? Yes, you can. PBMT, photobiomodulation therapy, is the novel drug-free approach to practice painless pediatric dentistry. And you can do that if you understand the pain pathway and where you are intervening. So apart from blocking TRPV1, which we had discussed during the transduction and transmission phase of the pain pathway, laser PBM will enhance the release of serotonin and noradrenaline. So you now understand the Melzack and Gates control theory revisited, where we are shutting the door at the level of the DRG. So the impulses cannot move forward. So by using this as a simple strategy, you can achieve profound pain control in children. So the mechanism of action could be a little complicated. We call it as transient axonal vesiculations. It's like twisting an axon. So the action potential, which was supposed to fire or jump from one node of Ranvier to the other, gets blocked in between. Plus, like I told you, there is increase in the release of endogenous painkillers, enkephalins, endorphins, serotonin. And that's how it is a beautiful way of not just blocking peripheral stimulation, but also changing central perception and preventing central sensitization. So where can you use PBM? Left, right, and center. Before LA, in place of LA, grade 3 extractions, no need to give an LA. Grade 2, sometimes we do, sometimes we don't, depending on the threshold that the child is showing. In grade 1, you can use it as an adjunct to injections. You could use it before pulpectomy, after obturation. You could use that for before your LA injection for a firm extraction, after extraction. It prevents a dry socket. It is the best way to prevent myofascial pain dysfunction, best way to prevent and treat oral mucositis. Preemptive analgesia is again something that we are not very familiar in as pediatric dentists, but this is something that is so important to reduce central sensitization. So using PBM as a preemptive analgesia, whether you want to use a block or an infiltration later, is left to you. But always start with preemptive analgesia so that you reduce the load on the CNS and you don't end up resensitizing it. Right? So unveiling the science behind laser analgesia, it's not just going to have an inhibitory effect on A delta and C fibers. It will slow the conduction by transient axonal vesiculations. It will reduce the amplitude of compound action potentials and suppress neurogenic inflammation. This is from the nociception part. From the central perception part, it will enhance the descending pathways to release noradrenaline and serotonin so that it can keep the gate shut at the level of the DRG. So you want to read about this, you can scan this reference. You will read this entire article on how exactly laser analgesia works. If you are skeptical about using it as a standalone modality, you can start with combining it before extractions. You will get a combination effect. My preferred wavelength for doing this is 810 nanometers. Why? Because it has the best blockage for TRPV1, which are so important as gatekeepers, which determine which nerve will fire an action potential and which one will not. Right? Some papers, again, you can scan the reference codes so that you quickly understand which paper I'm talking about, evaluating the preemptive analgesic effect of photobiomodulation on pain perception. Right? Let's not waste on the results. I can share these papers with you. This is how it is done. Very simple, non-invasive, pain-free therapy. We can still go ahead and give the injection after that if you need it. Various studies to show how effective this method is. Various laser tips that are used for this. Wavelength is important, and your specific tip to deliver the proper dose of photons to a pediatric tissue can only be achieved by using a pediatric PBM tip, not the adult one. So the choice of the equipment is very important. That's a pediatric PBM tip. It is only 3 mm in width, not the 8 mm which we use in adults. Right? Some more papers on how effective this is on the depth of local anesthesia. Even if you want to treat symptomatic irreversible pulpitis, you want to combine this strategy along with pain management with your conventional local anesthesia, you can do that with articaine, with lignocaine, with anything that you want to use. Post-operative flare-ups again get covered. What we do is, before we discharge the patient, we just laze it for 3 to 4 minutes at the site where the treatment was done. Right? This is the mechanism, again, similar to what we did in preemptive analgesia. What else can you combine that with? You can combine that with anything. You want to use that as a subgingival anesthetic gel, Oraquix, possible. You want to use that along with DentiPatch, possible. You want to use that with a topical anesthetic liquid, possible. Right? You can use that with Oraverse. You can use that with virtual reality, passive distraction, all the other methods that you want to combine to change the central perception. I also came across a paper which talks about counter irritation. When you're giving an injection, whether you're using laser PBM or TENS, you can also use a vibrator kind of a device which is called dental vibe, or there is another word for it called buzzy. So these are vibrotactile devices which will inhibit the nociception at the point where you are giving a local anesthetic injection. You can combine the strategies. So write this down. Dental vibe and buzzy are two vibrotactile methods which we can combine along with various things. This is what I just told you, vibrotactile devices based on the gate control theory again. For painless injections, you can use insulin syringes. My PGs who are listening to this will vouch for this, that they get fired every time they use a adult needle for pricking a child. Correct? So insulin syringes are always preferred. Buzzy device is something that is very unique. It will again create vibrotactile distraction, can be used along with LLLT or standalone when you want to use that as a vibrotactile mechanism to disrupt the signals in the gate control theory. What other things can you use based on gate control? Cryoanesthesia. You can use VR analgesia. You can use EDA, electronic dental anesthesia. There's some literature evidence to conclude pain and anxiety management for pediatric dental procedures using various combinations. Again, you don't have to search this journal. Just scan the QR code that I've given you. You will be able to access this paper. Effectiveness of hypnosis, like I told you, left to you. But the strategy should be clear that if you're blocking peripherals and stimulation, you have to change the central perception also. Whether you do that with VR, whether you do that with hypnosis, whether you do that with anything else, it's your choice. Codeine and opioid together, again, not very popular in India, very popular in the West. Efficacy of the buzzy device for pain management of children during needle-related procedures, a systematic review. Anybody who wants to read that, please scan the code. Effect of VR, distraction on pain and anxiety during dental treatment in 5 to 8 years old patients. Various non-pharmacological methods in the management of pediatric dental anxiety and behavior. Again, the so important preemptive analgesia that we talked about. This time they have used a drug for that. They've tried it with paracetamol, ibuprofen, or placebo. Acupuncture for pediatric pain, again, a part of the laser PBM strategy. Instead of using needles, we use the laser PBM device on specific acupuncture points to block the pain. This is again a new emerging field called laser acupuncture for pain relief. It is not just for dental pain. They are now documenting cases with sciatica, with spondylosis, with trigeminal neuralgia, where the acupuncture points were stimulated by using a laser in place of a needle, and it's giving wonderful results. I think that's it. A few of these papers which I can definitely share. That's my paper on use of laser PBM on post-operative pain after single visit endodontic treatment. Again, anybody interested in reading this? This was published in Children, journal from Switzerland, 2024. Anyone interested in reading can scan the QR code or send me an email. I'll be more than glad to share it. Conclusion: pain is a multidimensional experience involving both the sensation evolved by noxious stimuli, but also the relation and response to it. So if we understand the problem well, we'll be able to manage it better. Those are my references. Apologies if I short on the time. Any questions? I think I have, if the moderator allows, I can take a few of them.
Thank you so much, Dr. Shekhar. If you have time, and
Yes,
then
sir.
you can see the Q&A section, there are few questions by the students. Maybe you can copy the questions from the Q&A. Then you can write your answer into the chat box, because then it can be read by everyone.
I can only see Sivakumar Nuvvula sir's response, and
Can you see Q&A?
I'm already scared to read that. He's telling me physiology of pain and fear are important to know for applied basic sciences. Absolutely, sir.
and Chandrasekhar, can you see the Q&A section?
Sir, mujhe chat box. Acha, 1 second. Yes.
Q&A.
Sir, it's in the question and answer section.
Yes,
sir.
yes. I can see that.
So there are few questions. Maybe you can take up the questions from there, but try to write the answers into the chat box, clicking first everyone, so that everyone can read it.
Can I read that and then type it, sir? Anonymous
No.
attendee. Why fear and anxiety amplify pain?
Yeah. Like for example, I have selected this question, and if you can see my chat, the question is there, right? This question.
Okay.
Yeah, then you can type your answer here.
Yes.
If it is possible.
So
Like there are
you
only
don't want
4 or
me to
5.
answer it live? You want me to type it?
No, I think we can continue with the next lecture. In the meantime, you can just type the answer if it is possible.
I'll do
Is
that,
it
sir.
convenient?
I'll
First
do
of all,
that,
tell
sir.
me.
I'll do that, sir.
Check which what.
Yeah, Dr. Madhu, is it okay?
Sir, Q&A they can access, students. Chat they can't. If he
Oh, is it?
chat, he has to select everyone, then he can do
Sir,
it.
I'll
Okay,
quickly take 2 minutes, sir. Most of the things I've answered.
It's better. Then you carry on. Yeah.
Sir, what is non-pharmacological pain management? I think I talked about laser PBM. That is the drug-free way of shifting from pharmacological to non-pharmacological way of managing pain. That is answered. Preemptive analgesia. How many should we advise? I didn't mean preemptive analgesics, my dear friend. What I meant was preemptive analgesia is as important or in fact more important than what you do intraoperative and postoperative. It was in that context that I told you. Which one is better, PBM or TENS? PBM is better, but now we have devices which can combine both of them together. Which proton pump inhibitor can be used with NSAIDs in children? Wonderful question. I prefer lansoprazole. You can write it down. Lansol Junior is the name of the drug. That's a very good proton pump inhibitor, very safe for use in children. Lansol Junior. Sir, which drugs are safe in breastfeeding women? Not very much connected to this talk, doctor, but yes, you can definitely start with paracetamol. Sir, I think I've answered most of them.
Yeah, perfect.
Okay, sir.
Wonderful.
Apologies for overshooting on the time, sir. Thank you.
Thank you so much, Dr. Chandrasekhar. It was really wonderful to listen to you. It's always like that. Thank you so very much. Thank you.
Thank you.
And
Thank you so much,
now,
sir.
Dr.
Thank you,
Suresh,
Ravi.
we can start the next.
I would ask
Hello, sir.
Mr. Dave to present the certificate of appreciation to Dr. Yavagal, sir.
Thank you
Thank
so
you so
much,
much,
Dr.
Yavagal, sir, for
Yavagal.
joining
Please
us.
accept. Thank you. And Virendra,
The next
Srinivas,
presentation will be on systemic and
sorry.
topical fluorides by Dr. Shital Kiran, sir. Shital Kiran, sir, welcome, sir. I request Dr. Suresh PS, sir, to introduce the next speaker, Dr. Shital Kiran, sir.
Am I audible?
Yes.
Hello.
Yes, sir.
I'm audible?
Yes,
yeah.
Dr.
You're audible. Good afternoon. Good afternoon. I'm glad to introduce the speaker, today's speaker, Dr. Shital Kiran, to this Zoom platform. He has done his BDS from Bapuji Dental College and Hospital, Davangere in 1996 and post-graduation from College of Dental Sciences from Davangere 2001. Currently, he is working as professor and head in the Department of Pediatric and Preventive Dentistry, Bhavanagar, Gujarat. Area of interest are preventive dentistry, behavior management of child, dental trauma, and AI. And he is also chairman for Board of Studies, Bhavanagar, Gujarat. Today he is going to talk on the topic systemic and topical fluorides. I welcome Dr. Shital. Thank you.
Thank you so much for your kind introduction, Dr. Suresh.
Thank you so much. I would request Mr. Dev to display the presentation.
Dev, please share the presentation.
Topics. So coming to the 114 essential nutrients as per the WHO.
Slowly.
One of the essential thing. So
No,
fluoride is
slow.
present everywhere.
There, slow the
Good evening,
speed.
everyone.
Sir?
Reduce the speed. It's very fast.
Yeah.
You should do the normal speed.
We'll do a normal speed, please. Normal.
And we're talking about the systemic and topical fluorides. Good evening, everyone.
Normal speed.
Systemic and topical fluorides.
Normal speed, yes.
I'm Dr. Shital Kiran, professor and head at College of Dental Science, Mangal, Bhavanagar. So these are the common questions which have been asked as a long note. The following slide is a short note which have been asked from in the various university examinations. I will be covering the topics under this headings. So coming to the introduction, so among the 14 essential nutrients, as per the WHO, fluoride is one of the essential things. So fluoride is present everywhere, and fluoride is considered as a double-edged sword. The reason being, the fluoride goes above the normal limits, it will lead to some disease, and if it goes below, it will lead to some other disease or the condition. So that's the reason. Coming to the history, 1901, McCain coined the term colloidal stain. In 1939, Dr. Dean proved that fluoride causes mortal damage. Distribution of the fluoride in the body is everywhere, and the maximum fluoride which can be seen is in the cementum 4500 ppm. The fluorostatic mechanism of fluoride occurs by increasing the enamel resistance, and it reduces the solubility also. Then fluoride interferes with the block microorganisms, then it modifies the root morphology to some extent. It increases the rate of post-eruptive maturation, and also if there is an incipient caries, it causes remineralization. The maximum fluoride benefit can be during the process of tooth eruption, or when the teeth is already erupted or just erupted, and the fluoride is exposed to the tooth. There are various fluoride delivery methods, which is broadly classified into systemic and topical. So topical is once again divided into professionally applied and self-applied. Benefits of fluoridation. So what are they with respect to the primary teeth? It was seen that 50 to 60% caries reduction, whereas in permanent teeth, according to the anatomical structure, on the pit and fissure on the pit and fissure, 43%, 74% in the proximal, and 88% on the gingival surface. And also, if at all the caries occurs, then the progression of caries will be slower. Coming to the water fluoridation, it is defined as an upward adjustment of the concentration of fluoride in a public water supply in such a way that the concentration of fluoride ion in the water may be consistently maintained at 1 ppm by weight to prevent dental caries with minimal possibility of causing dental fluorosis. Coming to the water fluoridation, the recommended level of fluoridation is 0.8 to 1.2 ppm, and of course it depends upon the climatic condition. However, the optimal fluoride is 1 ppm, and fluoride was started first in the US in 1947 regarding the water fluoridation. And there are several classical landmark studies which we will go through. The Grand Rapids Muscon study was held for 10 years from 1945 to 55. So here the Grand Rapids was fluoridated and Muscon was non-fluoridated. And here in the Grand Rapids, there were 58% lower cavities was noted. Coming to the next study, Evanston Park study, which lasted from 1946 to 56. Here the Evanston was fluoridated and Oka Park was non-fluoridated. So obviously, the Evanston children had a caries reduction of 50 to 60%, and the permanent teeth had a maximum benefit of fluoride in this study. The Newburgh Kingston study was conducted from 1945 to 60. So it was quite a long of 15 years duration. So here the Newburgh was fluoridated and Kingston was non-fluoridated. So here, Newburgh children had a fewer dental caries compared to the Kingston. Usually the fluoride has no effect on the general health or the bone development or the IQ of the children. Ranford Sarnia Starford study was conducted between 1960 and 70. Here the Birmingham children of lower socioeconomic status had a lower dental caries rate. And this study proved oral health inequality can offer better protection to the disadvantaged group. Among the various countries in the world, India does not have fluoridated drinking water. And there are a few compounds which is used for water fluoridations. They are sodium fluoride, sodium silicofluoride, and hydroxyfluorosalicylic acid. This is commonly asked Viva question. The water fluoridation has advantages like large number of people benefits, less expensive, and during the tooth development, fluoridated water resists to the dental caries. So the disadvantages are there is interference by the human right activities, and common source of water supply may not be present everywhere. For any successful water fluoridation in anywhere in the world, including India, two things needs to be considered. One is there should be a centralized pipe water supply everywhere throughout the village, town, and the city. But unfortunately, India has 30% centralized pipe water supply. Coming to school water fluoridation, it can be effective only when there is a standalone water supply to the school. So it was begun in US in 1954. So here, what you should remember is the fluoride recommendation. It should be 4.5 to 6.3 ppm. So recommended regime is 4.5 times more fluoride than the fluoridated water. In the studies, it has been found that there is a 25 to 40% decrease in the dental caries. Coming to the advantages and disadvantages. School water fluoridation has advantages like minimal equipment are required and it is not so expensive. And if you look at that caries reduction, it is fair enough. So disadvantages like children will not benefit if they don't go to the school and if they remain absent. And the amount of water intake cannot be regulated. So that is one major disadvantage. And the school is not 365 days. That also we need to remember. Moving on to the next, salt fluoridation. It was done in Switzerland. The fluoride is sprayed with a solution of sodium fluoride or KF by batch or continuous processing. So here in the salt fluoridation, even the premixed granules of NaFCl2 can be added to the salt. So here the recommended concentration is 250 mg of fluoride per kg of salt. Mullerman 1967 is one classical study which went on for 8 years. The fluoride was 250 mg per kg, and overall reduction of the caries was 35 to 58%. All the materials are not perfect in this world. They will be having advantages and disadvantages, so as fluoridation. It has advantages like it is economical, feasible, and the caries reduction up to 40 to 50%. So disadvantage, consumption of salt is less up to 5 years of age, so it is not beneficial to younger children. And it is also not useful for a person who is having a renal disease or a hypertension. The milk fluoridation was promoted by Zilger. This is also from Switzerland in 1965. After Switzerland, it was followed by Bulgaria, where they did a community-based milk fluoridation. So it is encouraged for the children. So the caries preventive effect have been noted before the eruption of the permanent teeth. So milk fluoridation will be very much beneficial. For the milk fluoridation, 2.2 mg of sodium fluoride, 1 mg fluoride is added to 250 ml of the milk. So if you calculate 250 ml of milk bottle contains 0.625 mg of sodium fluoride. Here, the overall caries reduction was 60%. Coming to the feasibility in India, majority of the children cannot afford daily milk. And also, just like school water fluoridation, the quality of intake cannot be controlled. Moving on to studies of milk fluoridation, Inmura found 36.3% caries reduction, Russoff 35% caries reduction, and Zilger 31.5% caries reduction. Coming to the milk fluoridation advantages, disadvantages, as I said before, each fluoride component has both advantage and disadvantages. So the bioavailability of fluoride is not reduced by the milk. So it can milk fluoridation can be targeted at the community level, who are at the greatest needs, who can benefit maximum. So the disadvantages are milk is expensive, especially in the lower GDP countries. And if the child is having lactose intolerance, milk fluoridation cannot be indicated. Next, we have something called as floor fluoridation. So it is nothing but adding fluoride to the wheat flour during the milling process. So here, like the fluoride, if it is added, like it can be like a dietary supplement in the form of. So it is useful when water or milk fluoridation is not practical. And also like wheat is a staple diet. Coming to the advantages of floor fluoridation, it is cost effective, and of course it reaches a large population. But at the same time, it has also the disadvantages like quality control. Then the fluoride dose may vary with individual consumption. Like suppose a person consumes 1 chapati or 5 chapatis, it varies. Coming to the sugar fluoridation, the technical part here is sugar causes dental caries, and the fluoride prevents the dental caries. So what a combination it is. So it has been proposed actually in 1989 during the oral health program in Geneva. Coming to the fluoride supplement, so it is available in various forms like tablet, drops, etc. So here it is not available this over the counter. You need a prescription either from the pediatrician or the dentist, and the overall cholestatic effectiveness was 30 to 70%. So it needs to be consumed daily. The age group which it can be given is from 6 months to 16 years. However, we need to consider some factors like age, existing water fluoridation, concentration in the particular area, and the climatic conditions. Coming to the fluoride supplements, which was introduced in 1940. So it is in form of drops with or without vitamins. So it is available in 0.12, 0.21, and 0.5 mg. And fluoride tablets with or without vitamins available in 0.25, 0.5, and 1 mg. And also chewable tablets of fluoride supplements are also available in 0.25, 0.5, and 1 mg. Apart from this, oral rinse supplements like Swiss Swallow, it is available in 1 mg in a 5 ml liquid. So, children who are at the high caries risk and who drink fluoride deficient water, like for example, less than 0.6 ppm. So, here it can be indicated. Before administration of fluoride supplement, we need to evaluate the dietary fluoride, like the drinking water or what the child is consuming, like for example, the infant formula, juice, and the type of toothpaste which the child is using. So usually in infant formulas, powdered formula are reconstituted with fluoridated water. So if it is taken, it will be double the fluoride exposure, and eventually it will lead to increased risk of fluorosis. Infants may particularly are more prone because of large consumption of such liquids in the first year of life. The body weight is relatively low. So usually in the first year, if you see the dietary pattern, the liquid will be more in consumption. Coming to the fluoride supplement, commonly used are sodium fluoride and APF. The supplement in the form of systemic and topical benefits both the primary as well as the permanent teeth. So BP has conducted a study where he concluded that fluoride chewable that was stuck and swallowed was better than the fluoride pills that were swallowed right away. Feldman said that ingestion of the fluoridated tablet by the pregnant mother, it reaches the placenta barrier and it reaches the fetus and benefits offspring. Then the fluoride delays the tooth eruption, but it has some benefit. And the fluoride drop prescription should be proper, because if an incorrect dosage has been written, so that will cause a complication. Coming to the clinical recommendation, as per this association, they have divided less than 0.3, 0.3 to 0.6 and more than 6. You can just take a screenshot of this, and it is this one. Literature is available everywhere. Next, coming to the topical fluorides, it is defined as fluorides containing agents that are applied to the tooth surfaces at regular intervals in order to prevent the development of caries. The fluoride dentifrice was introduced in 1945. So it is an effective means for dental caries protection, and the fluoride components which have been incorporated into the toothpaste are sodium fluoride, stannous fluoride, and sodium monofluorophosphate, as well as amine fluoride. The fluoride dentifrice are classified as high potency fluoride dentifrice, that is more than 1000 ppm, and low potency, that is less than 1000 ppm. Sodium fluoride was the first component to be added to the fluoride dentifrice. Later, in 1945, 0.22% sodium fluoride dentifrice was ineffective, which was proved by Joseph. And also, by the same author in 1954, he introduced 0.4% stannous fluoride. So, amine fluoride was also introduced by Marthal, and sodium fluorophosphate was introduced in 1969. So it had advantage like almost a neutral pH. The monofluorophosphate showed 70% caries reduction in the studies done by Finn 1963, Myler 1965, Mola 1968, and so on. In the year 1975, Anlock said that caries reduction was greater in the proximal surface and also in the newly erupted teeth. Then Hargreaves and Lind also conducted a study on the fluoride dentifrice and found 30% caries reduction, which is fair enough. There are various recommendations of fluoridated toothpaste from various organizations. You can take the screenshot of this. Coming to the CPP ACP fluoride, this incorporated in this, and it is in a soluble form. So it is used as an active integrant to provide extra protection for the teeth. It buffers the dental plaque acid from the bacteria in the mouth and also protects the teeth from the acidic drinks and food. Even the fluoride was incorporated into the dental floss, so it is available as a fluoridated dental floss. Coming to the fluoride chewable tablets, so it is composed of sodium fluoride in the form of 0.25, 0.5, and 1 mg, citric acid, magnesium stearate, malic acid, microcrystalline cellulose, and it comes in orange flavor, sucralose, galact, and xylitol. So here we need to know about little bit about the pharmacology. Sodium fluoride acts systematically, that is before the tooth eruption, and tropically, that is post eruption. So it has advantages, like by increasing what it does is it increases the tooth resistance to acidic dissolution, and it promotes the remineralization, and it inhibits the karyogenic microbial process. Now coming to the fluoride mouth rinse, 0.05% sodium fluoride, which is having 230 ppm of fluoride and 0.44 APF solution, was tested weekly or bi-weekly in the form of rinse of 0.2 sodium fluoride, that is 900 ppm of fluoride. And it was found that reduction in the caries increments was up to 80%. Then the fluoride mouth rinse in combination with fluoride containing dentifrice, tablets, varnish or gels will be more beneficial. Here, the fluoride rinse offer little benefits over the use of fluoride containing dentifrice or tablet. So that is how it is called as chew, swish, and swallow regime. So the combination of mouth rinse and gel gave a good result, 30% caries reduction of course, in a community study. Fluoride mouth rinse can be used at home daily and in the schools also fortnightly, that is every 15 days once. So it is like almost similar to the community water fluoridation. Coming to the fluoride mouth rinse studies, Nixie in 1946 used 0.1% sodium fluoride and found there was no effect. In 1948, Roberts conducted a study where by using 0.01% sodium fluoride twice weekly, and he also said there is no effect. So in 1965, Torrell conducted a study with 0.2% sodium fluoride fortnightly and daily 0.5 sodium fluoride and found caries reduction at the end of 2 years, 50%. And Koch in 1967 found 23% reduction DMF using 0.5% sodium fluoride, mouth rinse bi-weekly. Houts in 1971, 44% reduction in the caries using 0.2% sodium fluoride. 1973, Huntwitz conducted a study where he found 30% caries reduction. Ripa in 1983 found 45% caries reduction with 0.2% sodium fluoride mouth rinse. Coming to the fluoride gel and foams recommendation from the various organizations. You can take the screenshot of this. This is about the fluoride mouth rinse. Once again, recommendation from different organizations. Coming to the slow release fluoride in the form of beads. The fluoride bead, it is bonded to the teeth to release the fluoride in the oral cavity over a period of time. So usually several years. So this was tried and tested with the intention of reducing the dental caries, and if any initial caries is there, to remineralize that. So it was used in the form of copolymer membrane type, the glass beads. So it has advantages like cost effectiveness, but the retention rate is one of the major disadvantage. Coming to endemic fluorosis, the water containing more than 1.5 mg per liter will lead to dental fluorosis. Then if it is more than 10 mg per liter, it will cause skeletal fluorosis. There is one term which is asked commonly in the Bible, endemic fluorosis. Here there will be crippling of the lower lip. So usually this is observed in people consuming jover. So jover has the ability to retain the fluoride. So endemic fluorosis is found in 22 countries, that is including the India. So in India, 15 states comes under the endemic fluorosis. So this is the fluoride level in the Indian states. So here you can see there is a lot of variation. You can just take the screenshot, and you should remember from which state you belong to, at least that amount of fluoride. So these are the other states among the 22. So here also there is a lot of variation. Coming to the non-skeletal fluorosis, it is usually involves skeletal muscle, GA mucosa, etc. Then the fluorosis muscle appears to be weak. Then the calcium content, the erythrocyte membrane will be lost. There will be problems in the infertility because of the less sperms or no sperms. There will be nervousness tingling sensation in the fingers, and also depression has been observed. The urine color appears to be yellow red, and bloated feeling happens. Coming to the professionally applied fluorides, the first one is the sodium fluoride. The method of preparation was advocated by Knudsen in 1947. 20 grams of sodium fluoride is in 1 liter of distilled water in plastic container is prepared for 2% sodium fluoride. And the number of application advocated is 2nd, 3rd, and 4th week interval. The recommended application is for 3 years, 7, 11, and 13 years of age. Sodium fluoride has a neutral pH, and the available fluoride is 9040 ppm. Here, the fluoride ion reacts with the silica, thereby reducing the free fluoride ions. In the sodium fluoride, the mechanism of action goes like this. Calcium fluoride is formed which interferes with the further infusion of fluoride to react with hydroxyapatite, and it is known as choking off phenomenon. It has advantages like chemically stable, acceptable taste, then non-irritant to gingiva, and does not discolor the teeth. And also it is not expensive. Disadvantages are 4 visits within a short period and just 30% caries reduction for that. Vibai found that there is a 45% caries reduction in the first year, 33% caries reduction second year, and 36% caries reduction in the third year, when 0.5% sodium fluoride was applied for 7 minutes, 3 times a year, 4 months interval in the first year, and in the second year's 2-month interval. Knudsen in 1942 found 39.8% caries reduction the first year, followed by 41.4%, and in the third year, 36.7% caries reduction when sodium fluoride was applied for 3 to 4 minutes. And this is one of the landmark studies. Knudsen in 1947 had applied 4-6 applications per year in 3 groups in the age group of 7 to 15 years. Then after 2 years, it was found 9.3% caries reduction in the 2 applications per year, and 20.1% caries reduction in the 4 applications per year, and 21% caries reduction 6 applications per year. As per Galgan and Knudsen, 2, 4, and 6 applications per year in 3 groups, age ranging from 7 to 15 years, they found after 1 year 21% caries reduction after 2 applications per year, 40.7 caries reduction in 4 applications per year, and 41% dental caries reduction in 6 applications per year. Also by other authors, once in 1970, he noted 11% caries reduction after 3 years, Svejada 34% caries reduction after 3 years, and Howell 23.6% caries reduction, Corel 20% caries reduction after 2 years. Coming to 8% stannous fluoride, the method of preparation was recommended by Muller in 1947. Here 0.8% stannous fluoride, it is dissolved in 10 ml of distilled water in a glass container. So usually the stannous fluoride has a pH between 2.1 to 2.3, so that is acidic. And the concentration of fluoride 19,360 ppm. And it needs to be always prepared fresh. Stannous fluoride should always be stored in a airtight capsule because it is highly unstable. So the mechanism of action is by formation of stannous trifluorophosphate. It acts as an anti-caries agent. The application is done using the cotton applicators. So during the application, the tooth needs to be kept moist for 4 minutes. And you need to do the reapplication every 15 to 30 seconds. And the number of application is 1 per year. Now we'll see the advantages and disadvantages of stannous fluoride. So rapid penetration of fluoride takes place within 30 seconds, and trifluorophosphate, which is formed on enamel, is more resistant to the decay than the enamel itself. So here the disadvantages are it is highly unstable, needs to prepare freshly every time. It has got metallic taste, and it causes gingival irritation as well as discoloration of teeth and restorations. As per Muller, the enamel powder treated with stannous fluoride was effective by proving reduced rate of acid dissolution, and enamel powder treated with stannous fluoride proved 3 times more effective than the sodium fluoride. Muller stated that 10 ppm stannous fluoride was superior to sodium fluoride. Howell said that 2% stannous fluoride, 83% caries reduction versus 2% sodium fluoride, that is 23.6% caries reduction. Thereby, you can see that amount of fluoride reduction is more in stannous fluoride. Nivet said that 2% stannous fluoride reduces 44% caries reduction when compared to the 2% sodium fluoride, where it reduced 35.9% caries. Then Gish conducted a study for single annual application versus Nedson technique of 2% sodium fluoride. And in the first year, stannous fluoride 21% caries reduction was found. And in the second year, stannous fluoride proved to be 32% more effective. And in the third year, 35% effective. As per Jordan, a single annual application of 8% stannous fluoride reduces 20% caries reduction in first year and 38% reduction in the second year. Asper has 21% caries reduction, and Shital 23% caries reduction, and Merker 69% caries reduction was noted when they used the stannous fluoride. Coming to acylated phosphate fluoride, it is nothing but an acidified sodium fluoride with phosphoric acid to gain the depth of fluoride penetration. It has a pH of 3, and it comes in solution as well as gel form. Gel is having 4 to 5 pH, and the fluoride concentration is 12,300 ppm. It is prepared by dissolving 20 grams of sodium fluoride in 1 liter of 0.1 mole phosphoric acid, and the pH is adjusted to 3, and the fluoride concentration at 1.23% by adding 50% hydrofluoric acid, and if it is required in gel form, a gelling agent is added. Coming to the application of APF, if you are applying a solution, the tooth needs to be kept moist for 4 minutes. Also, for maximum benefit, interproximal flossing can be done. And if you are using a gel, it needs to be applied either by paint-on technique or by using the foam tray. So the gel is having a property known as trixotropic, which upon pressure, it moves out, especially to the interproximal areas. The recommended number of application is 2 per year. APF has the advantage, like it is a flavored taste and highly acceptable to the children, and it is easy to apply. Then reapplication is not required. So this has advantage like it can be applied by the parent. Then caries reduction is greater than the solution when compared to the gel. Then the disadvantage are it causes gingival irritation, probably because of the acidic nature. then restoration of caries should be done as it causes irritation to the open caries. That you should keep it in mind. Redivold in 1963 said that phosphate containing fluoride has a maximum benefits, whereas Welcock 1963 proved that 66% cases reduction after 2 years of using APF. Also, the other authors have also proved the effectiveness is more in APF. Jordan said that there is a decrease in caries if APF gel is used. Graham has noted 45% decrease in the caries if the APF is used. Then Englander in his study found 60% decrease in the caries after 2 years. Coming to the fluoride varnish, it was introduced by Smith in 1964. So it is available in the form of Durafat, Flow Protector, Fluoritop, Duraflow, and Carex. One of the commonest questions asked in the Viva is regarding the isolation of fluoride varnish. No isolation is required if you are applying the fluoride varnish. But the fluoride varnish should be in contact with the tooth for 4 minutes, and it is applied semi-annual. It has advantages like it remains on the tooth for several days, and it also forms watertight protective layer. Disadvantages include patient cooperation. Then it is expensive. Coming to the studies regarding the fluoride varnish, it dates back from 1968, where they found 30% caries reduction. There's a lot of variation. But however, if you note from 1973 to 1979, all the studies are in 40% caries reduction. Our recent, not so recent, studies showed 63% caries reduction by Tiwari after 18 months, and Home 56% caries reduction after 2 years. Coming to the studies regarding Fluoroprotect versus Durafat, there was an animal study by the SIPA as well as clinical study. So Durafat 40% caries reduction, Fluoroprotect 66% caries reduction. Whereas in clinical human studies, the Durafat, there was 1.3 mean DMFS reduction and Fluoroprotect 0.5. Anthocyanium suggested high viscosity of varnish leads to penetration of the fluoride into the porosity by forming a tag, which acts as a fluoride reservoir. Coming to defluoridation. Defluoridation is a process of removal of excess fluoride from the water. So the defluoridation methods are divided into 3 basic types, and depending upon the mode of action. So the 3 types are first chemical reaction with fluoride. So that is an Alexander technique. And the second one is the absorption process, where the charcoal, process bone, activated alumina are used. And the third one is the ion exchange process. Here, anion and cation exchange resins are used. Next, coming to the fluoride toxicity. Acute toxicity, it's an excessive ingestion of fluoride over a short period of time, which produces acute toxicity. Wherever the chronic toxicity is excessive ingestion of fluoride over a long period of time, which produces chronic toxicity. So coming to the treatment, it should be aimed at reducing the amount of fluoride available for the absorption from the GIT. Vomiting should be induced, and milk can be given as it interferes with the absorption of fluoride, and the patient needs to be hospitalized. Thank you for patient listening. So if you have queries, you can chat in the chat box. And also, I want to express my gratitude for giving me an opportunity to speak ISPPD, thank you. President, sir, thank you. Secretary, sir, thank you.
Thank you, sir. Thank you so
Dr.
much.
Madhu, Dr. Srinivas, and his team, thank you so much for giving me the opportunity.
Thank you so much, sir. I think sir is answering all the questions live in the question and answer section. So we can move on to the next presentation. Before that, I'll request Mr. Dev to present the certificate of appreciation to Dr. Shital Kiran, sir. Thank you so much, sir.
Thank you so much.
The next presentation will be on preparation for writing theory paper and appearing in the vivavoce and practical exams by Dr. Sivakumar Nuvvula, sir. I request Dr. Varinder Goel, sir, to introduce Dr. Sivakumar, sir, to the audience.
Thank you so much, Dr. Srinivas. It's really a very special moment for me to introduce Dr. Sivakumar Nuvvula, sir. And I know him since I came into ISPPD as one of the office bearer. And we have already been always been associated and have learned a lot from Dr. Sivakumar. And he is Dean Academics and Head of Department at Narayana Dental College in Nellore. He was a professor and head at Meenakshi Annamalai Dental College, Chennai. And of course, he was the principal when we came in touch. He was the principal of Narayana Dental College, Nellore. He has completed his PDS from GDC Hyderabad and MDS from Manipal Dental College. And he is the proud past president of Indian Society of Periodontics and Preventive Dentistry. And he is life member of many national and international associations. And he was conferred with the very prestigious Dr. B.R. Vachar Award in 2018. And he is a fellow of ISPPD in 2016. And he is currently into the committee in which I'm the chair, that is in Education Committee International Association of Pediatric Dentistry. And he is into membership committee, IADT. Dr. Sivakumar, it's a really honored for us to have you here. And over to you, Dr. Sivakumar.
Thank you, Dr. Virender, for your introduction. Can I share the thing?
Yes, sir. We can start your presentation. Dev, let's start sir's presentation.
No, I have to live share.
Yeah. Okay. Dev, make sir host. Let me check. Yeah. Now you're the co-host, sir. You can start your presentation.
Yeah. Is it visible?
Yes, sir. Absolutely, sir.
Okay. Good afternoon, the panelists and all the audience. The initial thoughts about my topic is the saying, preparing ahead is of the job done, emphasizes the importance of thorough planning and preparation in achieving success. It means that when you carefully plan and organize your work in advance, you are already overcome a significant portion of the challenges involved. This leaves you with less to do during the actual executed plan, making the process smoother and more efficient. Always remember, MDS is a 3-year course with examinations at the end of first and third year. You have one theory paper, that is applied basic science, at the end of first year, and final examinations at the end of the third year, with 3 theory papers, 2 days of clinical examination, including pedagogy and viva. So my advice to all the exam going students is do not think about how the theory papers were done till you finish all the 3 theory papers. It only adds agony to you if you start thinking and discussing about every paper every day. And also the outcome of examination or the result of your MDS final till you finish the last one, that is vivavoce exercise. So when you are preparing ahead for your MDS final, you set your priorities right for each day, week, month, or 3 months, whichever amount of time you have at your disposal. Participate actively during your seminars, journal clubs, and case discussions, and try to add and discuss during those activities using other names and years. Make it a practice so that you remember better. Make a timetable by allotting few days or hours for each topic, and prepare notes, sticky notes that I mean, and flowcharts with a few international, national, and regional studies for a given area of specialty, subject, or topic. And also try to comprehend and memorize the flowcharts, keywords for each topic and question. Writing a good essay requires preparation of material that cannot be done in the limited time you have during the examination. So it is always see that you prepare ahead. It requires many hours or few days of preparation. And always, as you do, presume and anticipate the examination questions, whether you look at the previous question papers from different universities, different question banks, but always you have to presume or anticipate the questions. Then check the questions from previous examinations, as I mentioned, and try to understand the questions and what is being asked. That is very much important, because you have to understand the question and what is the primary focus of that particular question. Then only you can answer it better. Do you need to apply a concept or a principle to the past or current procedures? And do you need to compare or contrast different theories, techniques, or materials? Is very much important. Always envision yourself in the place of the paper setter or evaluator. What did the paper setter emphasize? Whether ask, describe, or discuss. So every word has a meaning. So accordingly, you have to analyze and answer the question. Practice writing. You may choose to write the summary of each topic you have been learning or discussing. Write a short description of past or contemporary events you have been listening to during your seminars or discussions. Focus on the clarity, conciseness, and understanding the differences between various theories, procedures, techniques, materials, etc. Always support your answers or statement with evidence, and this may involve memorizing some key concepts, events, or other names in an organized and chronological order, as you have been listening to the previous lectures. Dr. Shital has clearly mentioned in chronological order the years and others' names. Like that, you have to have that proper order. During the theory examination, don't try to display your personal affiliations or faith on the answer sheet, which can rarely help you. Do not give any instructions to the examiners on the answer sheets, like refer to page so and so for the remainder of the answer, page turnover, or to be continued, etc. You have to finish the complete answer before you go to the next question. So always keep this in mind, and do not waste the answer paper space. Always leave a small but clear left margin for the question numbers. Always practice putting the question number and also writing the question so that it will be clear for the evaluator. Remember that legible handwriting has no substitute. And do not give extra space or double space, but I advise you there should not be any crowding of the letters or the sentences. Try to use color pencils or highlighters to underline or highlight points of importance, which will draw the evaluator's attention. Draw diagrams wherever possible. Even line diagrams are better, as one picture is worth many lines or paragraphs. Remember that your full answer may not be read, but few paragraphs will be read as clustered samples by the evaluators. Hence, you have to direct the examiner's attention to the crux of the matter you want to show by highlighting the same, either by underlining it or using different colors or quotation marks or inverted commas. Remember that the length of the answer should be proportionate to the marks allotted to that question, whether it is a 50 marks question or a 25 marks question or a 10 marks question. You try to maintain the length of that particular answer accordingly. Answers to a long answer question in half page or short answer question in 3 pages will not help you. Do not write unnecessary stuff to just increase the length of the answer. Quality is more important than the quantity. And remember always to start an answer to a long answer question or long essay question on a fresh page. Don't try to write at the end of the answer sheet. Answer for a second short essay may start on the same page, provided decent space is kept after the earlier answer. Always try to organize the answer with proper structure for different types of questions and follow it uniformly. Many students may go blank after looking at the question paper, or may start writing desperately also if they are overwhelmed by the questions which they know after having a glance at the question paper. My advice is do not do this. Always close your eyes and try to recollect the answers for those questions. Okay, you can try the following. Read all the questions and instructions carefully. Organize the answers before writing. If you merely answer each question as you encounter it, you may answer or write information or material to one question that is more suitable for another. That's why I am repeating. Try to read all the questions through. Sometimes there will be overlaps, or sometimes the answer may be suitable for some other question rather than this question what you are attempting to write. So try to completely read all the questions and try to analyze and formulate the answers for each question separately. Time management, division of time based on marks allotted for each question is important. Remember that there are 180 minutes for the 100 marks, that is 18 minutes for each 10 marks. If you remember the morning's talk by Dr. Ansula, she has given the insights into writing a theory paper. She has allotted 45 minutes for long answer questions. Whereas for a 50 marks question, you will have 90 minutes in the third paper. Whereas for 10 marks questions, you have 18 minutes in which Dr. Ansula has advised for you to use 15 minutes for writing and 3 minutes for revision or to look into whether you have written it correctly or not. So my advice specifically is, when you look at the question paper, carry out a memory dump. All the memory what you have, just try to recollect and try to put it on the last page. Write down all the information you have had to remember for a question in a note of keywords on the last page of the answer sheet with pencil. I am saying with pencil so that you can rub it off later. Title it as rough work. Then organize your answer and present it in chronological order with a flow chart at the beginning. That will give the evaluator an impression that you know what you are doing or what you are answering, and you have put it in a proper order in a flow chart. Review your answer. Take a few minutes to reread and correct any mistakes. Check whether you have answered all parts of the questions and you have added the question numbers as I mentioned earlier, and also the writing the question. I want to mention about paper 3 only here. If it is an essay with recent advances, you need to have a flow chart, introduction with historical perspective of the topic, like older editions of textbooks and journals can help you in this historical perspective. Then definitions and terminology, if any, like recent AAPD or IAPD recommendations and guidelines. Changing views and trends over the years related to the topic, material, concepts, etc. What is the current scenario? You can go through the AAPD reference manual, the latest one, systematic reviews, and also the IAPD consensus statements. Then supporting literature from global, national, and regional authors from introduction to the current scenario. Other name and year may be enough for theory examination, but in clinical and mind viva, you may have to mention the journal names too if the examiners want you to answer. And conclusions with your own perspective, because remember that you have to give your own perspective also. After all, you are supposed to be a master and you are supposed to be receiving master degree at the end of this examination. Some resources to refer, as Dr. Anshula was also mentioning in the morning. Stewart, Barber, Troutman, and V. Scientific Foundations, Stephen Way, Pediatric Dentistry, Total Patient Care, Matheson and Primoz, Fundamentals of Pediatric Dentistry, Dean, that is McDonald's textbook, Casamasimo, Fields, McTighe, and Novak, that is Pediatric Dentistry by Novak et al. Related specialty textbooks like endodontics, orthodontics, etc. and topic-based textbooks such as, which is shown here, dental fear and anxiety in pediatric patients. And then the specialty journals, AAPD reference manual, AAPD handbook, if you can get something from your friends in US, then Dental Clinics of North America, Journal of California Dental Association. Many of these California Dental Association journals are theme-based and many are related to pediatric dentistry, dental anxiety, like that, are fluorides. You can have theme-based issues of California Dental Association, systematic reviews on different topics, then guidelines and recommendations. When you want to prepare ahead of the clinical examination and viva, prepare thoroughly on the theoretical basis for each of the clinical exercise from past to the current scenario. Develop knowledge on the signs, symptoms, prognosis of a given condition or treatment rendered by you. Have a scientific evidence base for the materials being used in pediatric dentistry. And remember the titles of the journals, textbooks, and the best journal articles, textbook chapters for a given topic of theory for the clinical scenario you are handling. That is a pulp therapy or a stainless steel crown case or a space maintenance case. And all our guest speakers have done justice, like the Kiran for pulp therapy, for Anshula for space maintenance. If you can remember all those things, like crowns also, the Priya, if I am not mistaken. And please go through those lectures again if you get it on ISPPD website, and you can have a good amount of material. Work on each clinical case with time frames and quality assurance 3 to 6 months ahead of the examination, and have mock practical examination drills with rubber dam 3 to 6 months ahead of the final examination. Whenever possible, train your allotted clinical assistant, that it can be your junior or an intern or a attender in your department, for orientation to assist you chairside. Prepare checklists for all the clinical examination procedures and follow meticulously. Memorize the composition and properties of materials used for the clinical procedures for chairside discussion, if any. Remember that 2 days of clinical examination, pedagogy and viva, you have day 1 pulp therapy, stainless steel crown, and adaptation of a band, and making an impression for space maintainer, and selection of a pedagogic topic. On the second day, you will do the evaluation and segmentation of the space maintainer, pedagogy presentation, and vivavoce. As I mentioned earlier, it's 2 days examination with 3 procedures, pedagogy and vivavoce. Don't panic. Don't think about the result. Keep calm, relax, and do better. As I mentioned earlier, have checklists for all procedures regarding principles, equipment, and materials, along with some landmark studies. Keep all study costs, radiographs, mixed dentition analysis chart, Instruments for each procedure are ready as required. All infection control protocols to be strictly followed. Avoid touch with gloved hands the areas other than defined. Always remember, the examiners will be observant on this type of thing. Always prepare the patients on your own. Don't leave it for any of your juniors, the exam patients, so that you can build a rapport with the patients. Practice four-handed dentistry with your chairside assisting junior or intern. Make sure you have treated every dental problem for the child other than the exam exercise. Be very specific in selecting exam cases, as they should be for the exact specification. Well begun is of them. Prepare all diagnostic records, casts, radiographs by yourself, and avoid blaming someone else for the faults or errors, mostly your juniors. Have some juniors, interns to keep the waiting parents or children occupied. Bringing the parents and children at different timings as per the expected time to start the procedure can help. Before seating the child in the dental chair, allow the child to finish restroom formalities. Keep the child occupied with some games, activity during the chairside presentation or viva. Keep some chairside reference materials, handouts, do's and don'ts, checklists related to the clinical procedures with supporting studies. During clinical examination and viva, use protective eyewear for yourself as well as the child patient all through the clinical procedures, including crown and band adaptation. Chairside parental presence or absence should be decided and handled carefully. Keep a watch to the time of your procedures, as it is an important tool to win the prizes of your examiner. Listen carefully to the question and answer to the point, as your answers can lead to further questions. You don't answer it correctly. Always have a backup to your answer, that is supporting literature, a journal article, or a textbook chapter. And in case of accidental maltreatment or mistakes during your treatment procedures, you should be able to analyze the consequences and the management and the answer appropriately. On the day prior to your examination and viva, assign responsibilities for your juniors, friends, or relatives, or if you are married, your spouse, regarding transport of children, parents, refreshments, as well as chairside assistant. Check for all the study costs, diagnostic records, instruments, and materials. Have a checklist of do's and don'ts for each procedure, as mentioned earlier. Revise the theoretical basis of 3 critical procedures from past to present regarding the diagnosis, materials, and techniques with supporting studies. It was also mentioned earlier. Pulp therapy. Check for all the diagnostic records, checklists, instruments, and materials. Write thorough history, clinical findings, and write down the diagnosis, differential diagnosis, and treatment planning, along with the necessary radiographs, pulp sensibility tests, and any other investigation. Don't try to fabricate the diagnosis for your convenience. Don't teach the child to lie about symptoms and signs. Proper pain history. Use the right terms to describe the pain, spontaneous, continuous, etc. Each description is unique and cannot be interchanged. Combination of these terms that can lead you to decision making. Always remember the AAPD reference manual about these things, about the flowcharts given about the diagnosis of pulp pathology. Good radiograph with adjacent tooth contacts and underlying tooth bud. A good bite wing with adult film than an IOPA with pediatric size film will be better. Measure the working length with 2 different file sizes for mesial canals in mandible and buccal canals in maxillary, so that you can differentiate between mesiobuccal, mesiolingual, mesiobuccal, distobuccal. Handout related to diagnosis of pulp pathology, different observation materials and techniques, as well as studies supporting or conflicting those materials and techniques will be useful. These are some ready references, which is they're given in the ISPPD block 2. You can go through. For space maintainer, selecting a child with fully erupted tooth, that is first permanent molar distal to the abutment tooth to be banded is always better. Knowledge on dynamics of changes in occlusion, secondary spacing, canine movement, lower anterior crowding, establishment of molar relationship, guidance of erection, occlusion, etc. As mentioned earlier by Dr. Anshula, you have to have all the information and knowledge. Band dimensions, composition, loop dimensions, modifications, welding and soldering, strain hardening, and about the instruments, you need to have the knowledge. Sectional impressions are always better, and the stabilization of the band in the impression is important. Different methods of stabilization can be also asked. Then when you have both the upper and lower cast with you, don't think about making both impressions. And always try to have a sectional impression if it is allowed by your examiners. Stainless steel crown, you need to have the indications, types and sizes and composition differences. Basic principles of preparation, different schools of thought about preparation of crown to suit the stainless steel crown. Protection of the adjacent tooth during preparation using a band material or a matrix band. Alterations are in the stainless steel crowns and also different luting cements for stainless steel crowns. So preparations maintaining the greatest amount of buccal and lingual tooth structure for the most retentive. Cement significantly increased the retention capacity of all preparations. Mechanical retention did not contribute significantly to the separation resistance of stainless steel crowns. Factors other than retention may be of greater importance to the clinical success of stainless steel crowns. You can follow this particular article by Saved et al. In 1979. Pedagogy, the purpose is to assist, guide students' capability as a teacher, should be divided into must know, desirable to know, and good to know. Should not have more than 8 sentences per slide, and focus on the diagrammatic representation. Use a lot of pictures or diagrams. Extempore presentation is always appreciated with footnotes for important facts. Number of slides should be 1 slide per 30 seconds on average. Focus on content and presentation rather than overdoing and distraction from the topic. If someone else's work is presented or taken, don't forget to acknowledge. And the students should have thorough knowledge or control on 2 to 3 topics. If a choice is given by the examiners for pedagogy or vivavoce, you can select from those. However, be prepared for any topic that can be given by the examiners. Thesis or dissertation presentation is not pedagogy. Pedagogy is teaching skills for a given target audience or students. You should know the target audience and time allotted and prepare and present accordingly. Topic should be planned well before the day of the pedagogy on the first day. Should have thorough knowledge on the topic, and the presentation should aim the target audience. If possible, one mock session with your faculty and other postgraduate students will be better. As it is a pedagogy activity, presenters should cover all the areas provided as per the DCA checklist, which is there in your curriculum. Coming to vivavoce, it is a Latin phrase meaning with living voice or live voice, but most often translated as by word of mouth. A viva is a university examination in which the student answers questions in speech. The student's response to the assessment task is verbal rather than in writing. Vivavoce is a form of oral assessment that helps students develop valuable communication skills. These are helpful for examining a significant part of the syllabus, allowing students to think on their feet and express themselves meaningfully, demonstrating students' ability to reflect and think critically in real time, distinguishing between superficial and in-depth learning through an interactive dialogue between the student and the examiner, the objectively examining the factual recall, applied knowledge, ability to synthesize the information, communication skills, everything is examined. Always do not think that why me when you face vivavoce. Don't be reactive, but be proactive so that you have the potential to choose your response by taking a pause and having your self-awareness and using your conscience and creative imagination and your free will in responding to the viva questions. 10 tips for success during your vivavoce. Number one is smart preparation. Don't try to revise everything prior to the vivavoce, as examiners can ask from any area of pediatric dentistry from history to the current scenario. Try to compile all your learning and experience over the 3 years and try to manage. Prepare better on 2 to 3 topics other than the clinical case scenarios with good literature backup. You would be fortunate if you were asked to pick your favorite topic. Reading comprehension strategies given in this picture. So reread the test so that you will have more information, so more understanding. Activate prior knowledge. What do I already know about this? Then try to build on that particular thing. Use context clues. Infer the meaning of what you read, that is reading between the lines, and think aloud, talk through it. Then summarize the story with characters, setting, problem, and solution. Locate the keywords and memorize them. Make predictions, think, pay, and share. Use word attack strategies like rereading, reading. Like you can break the difficult words or terminology and try to practice. Visualize. Use graphic organizers so that you can better remember things. Evaluate the understanding. Then prepare a list of most difficult questions. List your top 10 most difficult questions and keep preparing, discussing them with your faculty, seniors, or juniors until they no longer scare you. Be yourself. Don't try to imitate someone else. However, you can improvise by observing or listening to other people. Realize what is best for you and prepare accordingly. Present yourself better, dress smart, show positive body language, and be audible. A formal dress with or without a tie and a neat apron will add to your personality and self-esteem. Don't wear jeans, t-shirts, or fashion accessories. Be positive. Enter always with a positive attitude. Examiners will be interested to know how much you learned during the 3 years of your PG, and just they want to pass you. Nobody will enter into the examination area with an intention to fail you. Remember this. Thinking about the results before you finish all the areas of the examination will only reduce your chances as you become extra anxious and defensive. Answer with confidence, but politely and humbly. Back to basics. Prepare for the warm-up or an icebreaker question, because sometimes Viva will be started with fundamentals. Sometimes you will be worried because you will not prepare about the fundamentals. So always remember about the fundamentals, definitions, etc. Most of the time, a Viva will start with a warm-up or icebreaker question, and your answer will set the tone for further Viva. Most students take these things easily and ignore them, as they think they are basic and usual level questions. Hence, be prepared for those must-to-know questions. Well begun is half done, as I mentioned earlier. Always get off to a good start. Listen carefully. You have to care to listen to the questions. Try to understand the question. Check your perception. When in doubt, you can always ask the examiners to repeat if you couldn't get the proper meaning of the question. Answer the question relevantly. Don't give non-specific and leading answers, because for every non-specific or leading answer, there will be a specific and right question, and you will be in a quicksand before you realize it. Don't talk like a salesman or a representative. Don't try to remember answers by heart. Analyze and understand the question or subject. Otherwise, it removes the spontaneity in answering and will be evident to the examiners. If you are anxious about your prepared answers, there is more chance of answering questions that were not asked than the ones they are. Why? Because you already prepared some questions, you are anxious about that. Whatever the examiner asks, that will be hard by you as the question what you have already prepared. So be careful about this. Stay calm and relaxed. The examiners will be genuinely interested in knowing how much you had learned or prepared, as I mentioned earlier. So be confident and comfortable so that you can do your best. The lack of comments should not be disturbing. Sometimes you might be worried because the examiner didn't say, good, you answered well, like that. A lack of comment does not mean that you have not done well. Some examiners may not indicate whether you have done well or not. So the do's and don'ts, do follow the tips mentioned earlier. Refrain from wasting your time asking your batchmates who finished Viva ahead of you, because nobody want to sacrifice their thing to you. So about the questions and the examiner asked them, the questions which they couldn't answer, they definitely will not tell you that, so that you will prepare and go and answer better than them. So it is a waste of time asking your previous student. Be thorough with your dissertation and library dissertation topics, because in Viva they might be discussed or asked some questions. Prepare for what you missed during the chairside clinical Viva, and also your theory papers, and prepare well for them. And the examiners might ask you and the same, and please come prepared with. During vivavoce, as I mentioned, remember these things also. Stay calm and focused. Listen to the person carefully. Perception check in case of doubt or lack of clarity from the examiner. Pause to recollect the information to answer to the person, and respond with ability. My thanks to Dr. Anshula Deshpande, Dr. Nikhil Marwa, Dr. Sharat Ashokan, Dr. A.R. Prabhakar sir for providing some insights when I was preparing this topic, and also Dr. Prabhakar, Dr. Sudha, Madam, and also Dr. Shobha Tandon, who are my teachers during my post-graduation, for setting up the platform for excellence in pediatric dentistry. My gratitude to the ISPPD head office, Dr. Kiran, my good friend, Dr. Virendra Goyal, and also Dr. Madhu and his team from the Department of Pediatric and Preventive Dentistry, KLD Societies, Institute of Dental Sciences, Bangalore, India. Thank you all for remembering me and giving this opportunity. Thank you.
Thank you so much, sir. Thanks a lot for wonderful insight and letting everyone know that how to attempt questions, answers properly and in a nice format. Thank you so very much. And I'm sure it's really going to be very, very helpful for the postgraduates. And there are a few questions we can quickly take up, I think. Sir, how to choose 50 marks question in the final paper? I don't know how easy will be for you to answer this question.
No. I'm telling you, like if there are two easy questions and one somewhat difficult question, I always advise my students to go for the difficult question.
Yeah, that's right.
That will give you actually more marks compared to the easier question attempted by other students. So I always say that go for a difficult thing.
Yes, sir. Absolutely. What to write in summary or conclusion, sir? Just in few lines.
Like the gist of what you have discussed, and with your own opinion. That's what I mentioned, because you are supposed to be a master at the end of the 3 years. So your opinion, your insight also matter. So in conclusions, you put your insight also, your point of view also, along with what you have written with the literature review and what you have studied.
Yes, thank you, sir. I think another and one article they have asked Sabidi et al. And if you have anything, sir, any article you want to share with the
I can share with you so that you can share across.
Yeah. Well, I will upload into the Telegram group which we have created for the students for all the information, and that same group is for the life members also, so that we can share all the informations in future also in that group.
Right.
And thank you so very much, sir. Thank you. Thank you. Dr. Suresh?
He is not.
Okay. He must be.
Yeah, he had a meeting, sir. He had attended a meeting.
Yeah, I know. No. He told me that he may be leaving the meeting because of this particular one meeting. Maybe some admission issues. Yeah.
Yes.
Okay. Anything left we have now except for valedictory? Dr. Madhu?
No, certificate.
I
Certificate.
request
Yeah.
Mr. Dave to
Certificate of
present the
appreciation.
certificate of appreciation to Dr.
Yeah,
Sivakumar, sir. Thank you so much, sir.
Thank you.
Thanks a lot, Sivakumar, sir.
Thank you, Madhu, and all the team.
Thank you, sir. Thank you. Thank you so much, sir.
We thank Dr. Varinder Goyal, sir, and Dr. Suresh B.S., sir, for moderating the session. I request Mr. Dave to present the certificate of appreciation to Dr. Varinder Goyal, sir, and Dr. Suresh B.S., sir. Thank you so much, sir.
Thank you. Thank you so very much.
Sir, just to conclude, I thank our President, Kiran sir, and our Secretary Varinder Goyal sir for giving us an opportunity to host this program. And thank all the moderators and speakers, sir, for their valuable time to spend with the students. Thanks a lot, sir.
Thank you so much, Dr. Madhu. Dr. Madhu, President sir is joining us? No, you're muted.
No, sir.
Okay, no worry. Without further delay, I would like to convey a formal thanks to Dr. Madhu. Of course, your team, Dr. Madhu, which includes Dr. Srinivas, Dr. Ravi Kumar, Dr. Kriti, Dr. Virendra Singh, and your staff. I'm really, really thankful to all of you for taking this task so judiciously, honestly, and dedicatedly. And certainly, I would like to convey thanks to your dean, your principal, Dr. Srivatsa Ji, sir, who has spared all of you for this particular task. I know there are a lot of work you all must be doing into the institution, but he spared all of you for around 15 days for ISPPD. Please convey my formal thanks to Dr. Srivatsa, sir, and your management, of course. Yeah, and I would like to offer you, give you a certificate of appreciation, a token of gratitude. Of course, I will be sending you the hard copy of the certificate by post within this week for all of you. And but I would like that we should display that certificate right there. I may request Dave to display the certificates of appreciations for Team PediaRare 6 2025. Dr. Madhu, you have really done a wonderful job. I think this is one of the best rapid revision program because we used to have maximum 500 capacity platform, but this time we had to increase it to 1,000 because the registration crossed, I think, 1,200, but they will be able to give me the precise figure, but we crossed more than 1,400, I think, or 300 registrations. And at one time, we had around 900 attendees on this platform.
Yes.
And then we made it live on Facebook, and around 832 attendees were there when I looked at the data on first day, but after that I couldn't check it. But that was amazing. And not only people from India have attended this program, many countries have attended this program. I could see from the registration list that the people from Nepal, from Brazil, from Peru, from a few countries from Europe, Turkey, UAE, Sri Lanka, many people have joined our program because many of you must have shared the link of registration with the other people. And I was very happy that our students are globally learning from our ISPPD platform. And all thanks goes to you and your team for
Yes, sir.
this wonderful job.
Thanks a lot, sir.
So very much. Thank you.
And this time there are minimal technical glitches also. That is
Yes.
Because, sir,
Thank you, sir.
we are not technical people, so sometimes it happens. But Dev at our team, who is from Uniglo, he's always the backbone of all technical things, and he always makes sure that we do this job without minimal glitches. But after all, it is technology. Everything depends upon the network. So sometimes it happens, but definitely sometimes it happens. But another information for all of you is we will be uploading the recordings of these lectures on ISPPD website. Vasudev has already started working on it. He will be uploading the recordings on the website, and you will be able to access those recordings and you can learn it. And I'll request Vasudev to do it within this week so that we don't waste much of time. And time is precious for the postgraduates. Exams are coming near. So it's better that we should upload the information, upload the videos as soon as possible.
There was the request of one of the participants to see Dev's face. His name has been mentioned quite a lot these 4 days. One participant has mentioned, can we see Dev's face?
Dev, can you come online and show your face? Dev, are you there?
Yeah, sir, I'm there.
Yeah, you show your face.
Please go live. There are a lot of students.
Just
now.
go live.
I could not see you.
We want to see you there.
Okay,
Why
sir.
don't you on your camera and show your face that who is behind this whole program?
Okay.
Yeah. You know, Madhu,
thank you, Dev.
even I am seeing his face for the first time. I always, talk to him maybe thrice or 4 times in a week, or sometimes 4 times in a day. But I have first time seen who Dev is.
Thank you, Dev. Thanks for all the help and support.
Thank you.
Thank you so much. Thank you, everyone. And if any technical issue happened, we apologize and we will try to rectify. And all of you will get a feedback form, survey form after the conclusion. I request all of you to just fill up those survey form so that it will help us in making this platform better, choosing the topics better in future. Thank you once again. Wish you all good luck for your exam. Thank you. Thank you so much. Thank you. Thank you all.
Thank you, sir. Thanks a lot.
Thank you. Thank you, all the speakers, all the moderators. Thank you. Thanks a lot.